Good morning, everybody. A very warm summer welcome to you at our PCA webinar. We will just give everybody a few moments to join the meeting. And my apologies in advance that we've had a few technical issues. So we're a couple of minutes late starting. So thank you ever so much for your patience in holding on. We have had pretty good fortune, I think, across all of the webinars we've been running in the past year and a half, owing to lots of hard work from people like Alicia, and also a good dose of good fortune with internet connections holding up. But we've had a bit more of a struggle today. So we'll just give everyone a few moments to join us, and then we'll start off. So just while people are joining, my name is Seb Crutch. I'm one of the psychologists at UCL and the Rare Dementia Support. And if this is your first time joining us on these PCA meetings, my warmest welcome to you. I'm really sorry not to be seeing you in person, but thank you so much for joining us. And you are amongst friends. And we've got, I hope, a great program for you today. We obviously have been struggling over the past year and a half with not seeing you all face to face. And I think this is our 5th webinar that we've done online rather than meeting together physically. So just to reassure you, I realize we're all feeling a little bit unsettled at the moment, not knowing exactly when or how things will resume. So just to reassure all of you that we will do our level best to get back to physical meetings, but also to keep the best of the online and virtual meetings that we've been having, which we know have enabled a lot of people to join us who wouldn't normally physically be able to come because of distance, caring responsibilities, or other circumstances. So we will keep going with our online small groups and regular webinars, but also just to let you know that thanks to the hard work of Nikki and other members of the team, we're planning for our first face-to-face large annual PCA seminar back together face-to-face in person as well as online in April 2022. And we're hoping to have some opportunities sooner than that from October for some one-to-one and small group face-to-face meetings back in London. So we're making progress, but just to assure you, we won't be throwing out the good things we've learned about online meetings as we get back to face-to-face catch-ups. Without further ado from me, we've got a great lineup today, starting with Robert Adams, one of our members, talking about PCA and giving a bit of an introduction for those of you for whom this is all very, very new and fresh, and that if you've had for example, if you've had a diagnosis recently. But just before we start with that, I wanted to give a couple of housekeeping announcements, if that's okay. One is that there is a Q&A box into which it would be great if you could put all of your questions. So rather than putting them in the chat box, please pop your questions in the Q&A box, and then we will organize those and throw those questions to the panel towards the end of the session today, so they can give you the best of their wisdom and insight and experience. And just to remind you, there's a little post as anonymous tick box, which you can tick if you don't want anyone to know who the question's coming from. You are also welcome to use the chat box. Try not to use it for questions, but if you want to make comments about the meeting, say hi to people, or generally amuse all of us who are attending, please feel free to. Also, to remind you, the webinar is being recorded. So if you need to step away at any point, don't worry. You'll be able to catch up with others in about a week or so's time, and we'll send you a link to that, so that if you miss any bits of the meeting or want to listen to anything again, please, you will be more than able to. And finally, just to say also, don't worry if you hear of great ideas or good resources and don't have the chance to scribble them down or can't remember them. Panic not. All of the resources that are mentioned today will also be included in the post-session email that we send around to you, along with the link to the recording. Okay, so without further ado, It's my great pleasure to welcome Robert, who's a fantastic and long-standing member of the PCA support group. And he's going to be giving a general introduction to PCA from his perspective. So this is pre-recorded, and I shall hand over to Robert now.
Well, hello. It's very nice to be here today. I've been invited to talk about PCA, and it's a privilege to be with you to be able to do so. By way of introduction to this spot in the programme today, I am not a clinician, nor am I a qualified health professional, nor am I an expert in the causes of PCA disease or its diagnosis or its progression. However, my only claim to knowledge of the effects of the condition and enabling me to speak about it is that I do have 11 years lived experience of being with and later directly caring for my late wife, Catherine. She was first diagnosed with probable young onset typical Alzheimer's disease in 2011, and she later developed PCA. This was noticed in the process of tracking my wife's progression with dementia after referral to the neurology clinic at the National Hospital at Queen Square in London because of her other neurological complications. However, at the beginning of 2016, it was evident that she was additionally showing symptoms of PCA, which I had no knowledge of whatsoever. And the effects of this more rare condition became the dominant feature of the last 4 years of Catherine's life, much less so than the Alzheimer's and loss of memory. So through providing personal care to her throughout this period, both at home and for her last 18 months in a nursing home, I gained some insight into PCA, and I developed an interest in sharing this from a layperson's perspective in order to help others through the sometimes daunting challenges that this presents with the disease. I shan't embarrass myself by talking about tau tangles, amyloid plaques, protein and brain cell activity, or all that fascinating stuff related to the condition of PCA. There are several highly qualified experts of various disciplines engaged in the study of PCA and connected to the Rare Dementia Support Unit, who often work in parallel with the Dementia Research Centre at Queen Square, and who all know the subject in incredible detail and far better than me. Nevertheless, I hope to give you an overview and then talk about my experience, the things I noticed with Catherine looking after her, and our strategies for coping with everyday living at home. So posterior cortical atrophy, PCA as we all know it, is a rare degenerative brain and nervous system neurological syndrome that results in the deterioration of the normal ability to adequately interpret what one sees. PCA may be due to Alzheimer's disease, Lewy body dementia, or other neurological conditions, which do complicate the identification, measurement, and the defined effects of the PCA illness due to separate presentation of fading short-term memory and other related behavioral issues. It is more properly defined as an uncommon early onset dementia, which is characterized by progressive visuospatial dysfunction, visual agnosia, and topographical disorientation. And in PCA in the early stages, memory and insight typically remain relatively intact if they're not associated with Alzheimer's. Gradually declining vision of the affected person is due to brain cell deterioration or decay. It's not to be confused with compromised eyesight or poor eye health, but really it's better to be considered as the effect of the disease upon a person's what we call brain sight. And common indicators of the condition include difficulties with general reading, writing, judging distances, shapes, colours and textures, a lack of spatial awareness of one's general surroundings, and a real struggle sometimes to recognise everyday objects and familiar faces. Of itself, this condition may possibly cause decline in memory and thinking abilities, our cognitive skills, and specifically in my own observation, they just imperceptibly fade away over time, often without a marked and noticeable step change. But I must qualify this: no one person's journey with PCA and its effects upon the individual is necessarily the same as another's. So to talk about vision, things may appear to a person with PCA to have unusual colour, they appear distorted, or they may look like they're moving around when in fact they're stationary. Objects become less recognizable. People may struggle to recognize objects out of the corner of their eye, or might see many different objects close together as one object. Catherine had real problems with peripheral vision, and anybody coming up behind her or from the side used to really surprise her and sometimes frighten her. Surfaces and depth can look different. For example, a black puddle may look like a hole in the floor, or it may be difficult to find and reach for a door handle. When we were traveling out to see our family in Singapore, we had to go through Dubai Airport, and part of the process of the journey was to cross from one terminal to another, and we had to go through an enormous departure lounge, which typically in Dubai had a marble floor. And Catherine was absolutely terrified of walking across it, and we ended up walking around the whole of the perimeter because she thought this space was actually a swimming pool. People may still see an image when they're looking away, so they'd be looking at something, and as they look away, they still see it. And often they will see more than one object at a time when in fact there's only a singular object. And people with PCA may not always be able to see what's right in front of them, and often will bump into things. And furniture is often a real problem if it's not in an open space. People with PCA also have problems with reading, often losing their place on a page, missing out lines, the letters, jumbling up or finding it hard to read certain fonts particularly, and incredibly with handwriting. And this does affect everyday tasks like putting in a PIN, using a cash machine, or signing paperwork. People with PCA have difficulty with judging distances and depths. So crossing roads or using escalators or stairs can become very difficult. And we did find that traveling to London, using the tube, particularly minding the gap was always a huge obstacle. And also traveling with bright lights and patterns. A person with PCA may reach out to grasp an object, but completely miss it because they can't judge how far it is away. And spatial awareness is also a difficulty. Some people with PCA may struggle with their sense of direction, and terms like left and right may be harder to follow. However, with Catherine, way before she was diagnosed with either Alzheimer's or PCA, being Irish, she could never determine left and right. Traveling with her in a car and a map was a nightmare for me. People with PCA often have difficulty recognizing objects or familiar faces, especially when they're not in plain sight. And people may experience difficulties reading the time on a clock or a watch and signs, and particularly struggle nowadays with digital clocks or screens. So computers are often more difficult to manage. And people with PCA also have difficulty with light sensitivity. They find bright light very uncomfortable and don't like glare from shiny surfaces. So keeping the kitchen surface highly polished is not a good idea, although from a cleanliness and hygiene point of view, highly recommended. But being a chap was often sometimes way down on my task list. Colours also another problem, and particularly very highly patterned objects or materials or carpets. The pattern sometimes moves about to somebody with PCA, and the whole floor seems to be moving and shuddering, and that's a real distressing feature. And people with PCA very often have problems with coordination, particularly with dressing, for example. Catherine had major difficulty using buttons and zips, small buttons, locating the sleeves of the jacket while dressing, and putting on clothes back to front and trying to work out which shoe would go on which foot. So Catherine's situation was such that she couldn't be diagnosed in the normal way with an MRI because she had underlying conditions. So she had a number of tests, which were, she had a CT scan, a PET scan, a SPECT. She also had EEG, and she had a lumbar puncture, which she was admitted for in London. This was to try and eliminate whether she had epilepsy or any other condition which was causing her the problems. However, as we learned as time went on, the PCA became the dominant feature of her life, and we had to cope with that in a number of ways. And what I want to talk to you about now is just basically what we did and how I managed to live with her and help her. So during the normal course of the day, Catherine became often very weary, exhausted, and that was because there was so much brain processing that had to happen. she found this quite difficult, and she used to sit in the chair quite a lot. And she found watching the television to become more and more difficult. So classic FM was her savior. She loved classical music and just sitting there listening to it. Often she would be there with her eyes closed, but the eyelids would be fluttering, so she wasn't sleeping or unconscious. She was just sitting there relaxing and getting the best out of the day that she could. Getting up was always a difficulty. She would get up quite late in the day, and if I managed to get her up, washed, dressed, and breakfasted by 12 o'clock, I was doing incredibly well. She also used to want to go to bed quite early. And one of the features that she became familiar with was feeling what she called, I just want to be safe and comfortable. So she would often go to bed fairly soon after supper, not to sleep, but just to be in an environment and a condition where she was comforted and closed in a sense, with the bedclothes. Often we were surprised by the amount of conditions that arose from this. Predominantly, she, although she had a good appetite, she lost a significant amount of weight. She eventually had to go onto supplements to come back from what she was considered to be at risk. So she went down to just under 6 stone from 9 stone. So that was a really worrying time. She also became susceptible to falls, and this is something that one should try and avoid at all costs. So we moved all the things that were likely to cause her trip hazards. So the runners from the kitchen, the extra carpet in the lounge. We moved chairs so that she could navigate from her chair to another chair to the door frame and into the kitchen. And when she was seated at the table having meals, she would tend to loll from time to time. And even though I'd say, darling, please sit up straight, she would say, I am. So the sense of her compass and positioning in relation to normal upright was completely skewed. And when she would return to the lounge, she would often find it easier to back toward the chair to try and get the back of her knees on the edge of the chair, so she was certain and comfortable that she could then sit without a problem. Very occasionally she would miss this and sit on the armor chair and just sort of fall into the chair. The other problem she had was navigating stairs, and she adopted this process of kicking the riser with her toe to then move up step by step. And shortly into the process, I was introduced to a wonderful organisation. I just have to say that I live in Sussex, and we have a number of trusts looking after healthcare in Sussex, and this may not be typical across the country. But a particular trust had a small unit called the Proactive Care Unit, which has district nurses, an OT, a psychologist and a psychiatrist, and they're separate from the GP organisation. But they provided help and support to us, and the OT organised that we would get a rail put up the stairs and frame for the toilet, which was a wonderful suggestion. That then helped Catherine to get up the stairs. Getting down the stairs was a real problem, and she used to come down backwards, so she always felt she was safe because she could see where she was placing her feet. One of the things that we did organise fairly soon into her condition was that we arranged that she should write or update her will while she still had the capacity to understand what choices she was making and was able to sign. Her writing deteriorated quite rapidly, and she would write not in the spaces or on the line as requested, but somewhere on the paperwork. But if that was witnessed by a solicitor, that seemed to be okay. We also organised a lasting power of attorney, and likewise, I would recommend that anybody who has this diagnosis with a loved one should get powers of attorney drawn up, both for health decisions and finances. It's a relatively straightforward form, and the powers need to be registered for a fee, which is paid to the government, needless to say. But I found having this to be vital when it came to making decisions about Catherine's ongoing treatment, especially when she was admitted to hospital after a fall, because she was then unable to answer all the questions that were posed during triage and admission. One of the features of our living together and me looking after her was that she, fairly soon into the process, used to say to me, "Oh, just stop telling me what to do." And I had to learn fairly soon that I had to be very patient, and I had to coerce, encourage, and gently persuade rather than inform. Catherine being Irish, she did not like being told what to do. We also used to make an effort to try and go out at least 2 or 3 times a week. She loved going to have coffee. She loved sitting in a nature reserve nearby. And we also found singing for the brain to be a real tonic for her. The other thing I found extremely useful was because we slept separately after she was diagnosed because of her thrashing around through the night and disturbing my sleep. I invested in very low level lighting and had that installed under the back of the bed just by plugging in effectively baby lights under the bed, so it lit the floor, so when she wanted to get up to go to the toilet in the night, she could see where the floor was. And fairly soon in, I also invested in pressure mats, so I would know when she got out of bed and it would alert me. And I also eventually got those in the chair in the lounge, because that also helped me get on with other things rather than being in the same room all the time. And if I knew she was on the move, I would then go and intercept her to make sure that she was fine. So what did I learn from this? I think perhaps to say, be kind to each other. You have to be prepared to adjust your expectations and to revise long-term plans together. But I do encourage you to make the most of your time together. Just live each day as it comes, because they're never all the same and they will never be what you expected. But you can still do a lot and you can be content.
Wow, difficult for me to capture in a few words how grateful I am to Robert and to all of you who are willing to share your experiences, whether it's in a formal talk or informally to a buddy you've met over the phone or been introduced to by the direct support team, or eventually once we're back together over a coffee. Thank you so much, Robert, for a talk which is packed with great ideas and personal experience. And I think it really, really underlines, as much as you were very generous in referring to other experts at the beginning of your talk, I think it really underlines exactly how much expertise all of you in this meeting have. We all come from different backgrounds. We all have different expertise and experience. None of us know everything. And the whole point of these groups is having people share different aspects of their experience, whether they've been recently diagnosed or living with PCA for a long time, whether you have the condition yourself or caring for and about someone who is. And very much, Robert, they're capturing the essence of these groups, which we want to be genuinely a mixture of peer and sort of healthcare professional led. Both of we all gain from each other, and I personally myself have learned a lot from Robert's talks and the many encouraging and positive steps and strategies and adjustments he and Catherine made, both practically and personally, as they lived with their condition. So thanks once again, Robert. That's excellent. Right, for our next presentation, I'm very pleased to welcome in video, pre-prepared video form, a couple of dear colleagues, Emma Harding, who many of you will know is a co-lead of this PCA group, and who'll be chairing the question and answer panel later on, and also Josh Stott, a psychologist who leads the clinical psychology training course at UCL, and works very closely with us on the Rare Dementia Support Impact Study, and with a lot of expertise in young onset and rare forms of dementia. And they'll be talking a little bit about psychological impacts of PCA, and also highlighting a couple of different psychological techniques and approaches to trying to understand and support people living with these conditions. So Emma and Josh, over to you.
Hello everyone, I'm Emma Harding, Research Fellow and co-lead of the PCA support group. I'm delighted to be joined today by my colleague Josh Stott, clinical psychologist and associate professor.
Thanks Emma, and hello everyone. Yeah, so I'm a clinical psychologist, as Emma says, by background. So that means I tend to work with people to help them manage difficult thoughts and feelings, and often in the context of having problems with language, vision or memory, because I tend to work with older people with dementia, as well as people with rarer dementias too. I also am a researcher at UCL and trainer of other people trained to be clinical psychologists. And my research focuses on how we best support people with all different types of dementia to live as meaningful and good life as they possibly can.
Thank you, Josh, and great to have you here joining us today. Just to give you an overview, today we're hoping to briefly introduce some of the psychological impacts of PCA that we know people can experience. So that's from our research work, but also from the work that our direct support team do in conversation with members like you all the time. So we'll briefly summarise some of those. And we're going to briefly introduce one particular psychological therapy called acceptance and commitment therapy. And we're going to try and apply a couple of the key principles of that to some of the common problems that we know come up for people with PCA. And then finally, we'll just outline some current and future plans and possibilities that we've got to hopefully help you with some of these longer term, so where we hope the service and our research work is going. And just to sort of caveat this, so we know that we're not going to be able to solve any issues probably here and now in this brief 10-minute slot, but we just wanted to kind of start the conversation today, give you an example of an approach that might be able to help you. Hopefully it will inform you and empower you to go and seek out some more information about it if it sounds like a good fit for you. We can also signpost you to some resources if you'd like to get some more information. But longer term, we're really hoping to develop some resources with and for you to help you, but also any therapists or psychologists or counsellors that you might come into contact with to help them understand a bit more about the particular challenges that can come with PCA, so that they will hopefully be able to meet you a bit more where you are. Okay, so a couple of the common experiences that we hear reported, and these might or might not resonate with you and your own experience, but members often describe a sense of anxiety or worry, either about doing day-to-day practical things, so it could be quite practical tasks like making a hot drink, going up an escalator, but also anxiety and worry about the future and what's going to happen as things change. And people often describe as well a sense of frustration, so understandable frustration at not being able to do things that had previously been very straightforward, very simple tasks that may have been taken for granted, which have suddenly become very difficult, often because of the symptoms associated with PCA. So that could be things like reading, and this general sense of feeling a bit more dependent on and reliant on others.
So I guess the particular approach we are going to talk about today is acceptance and commitment therapy. And this is a form of therapy which aims to help people create a rich, full and meaningful life, while accepting the kind of pain that life inevitably brings. I guess within that, there are sort of 6 core things that we want to talk about today. So I guess what I wanted to do was just go through these and try and relate them to some common issues we hear about in PCA. So we're not kind of trying to produce solutions here, but we're just producing a few sort of ideas and thoughts and ones that maybe we can think about how to take forward. So the 6 things that I'm going to talk about today are, firstly, contact with the present moment. So a core part of ACT, or acceptance and commitment therapy, is called ACT for short, is contact with the present moment. And this means engaging with whatever's happening in the present moment, rather than getting ahead and thinking about the past or future. And it involves consciously paying attention to our here and now experience instead of drifting off into our thoughts. And it relates a little bit to what Emma was talking about earlier, I think, when people with PCA, but with many other problems too, find themselves worrying about what's going on or thinking about the future rather than focusing very much on what's going on for them right now. And sometimes we find, and not for everyone, but sometimes we find that what's going on right now is kind of less bad than the sort of thoughts and feelings that we're having. And so one way that ACT kind of helps us to do that is cultivating or helping people to learn what a skill of contact with the present moment. And they do that a lot through kind of mindfulness exercises as a way of trying to kind of stay in contact with what's going on now. And sometimes people use breathing exercises. So the second core thing of ACT is diffusion. And this means stepping back from and detaching yourself from your thoughts, being able to watch them drift by rather than getting caught up in them, and seeing them as just words and pictures that we can separate ourselves from, rather than something true and something we must hold on to tightly. And I guess the key thing here is that thoughts within ACT, thoughts are just thoughts. They're not you. there's a part of you that is separate from your thought. And many of us, because we've lived lives that are so caught up in thinking, have found it very difficult, or don't actually see any separation between what we think and us. And diffusion is about kind of helping us to move away from that. And one exercise that people often find really helpful is to sort of imagine their thoughts as leaves on a stream, and you just watch each leaf or each thought going past, as a way of disconnecting yourself from your thoughts. Or sometimes people actually say the word that their thought is backwards, as a way of kind of making it realize, actually, this isn't a reality, this is just a thought. It's something that I can relate to differently. The third principle of ACT is something called acceptance. And this is about realizing that there are painful things in life, and there are difficult things. And when you're living with a diagnosis of PCA, that is, one of those difficult things. It's not about trying to distract yourself from that or ignore that. It's about making room for these painful and difficult feelings, because often within ACT, the idea is that it's often the avoidance of those painful feelings, it's the sort of efforts to push yourself away from them that actually cause more problems than, in some senses, than the painful feelings and thoughts themselves. And it doesn't mean liking them. No one's saying that you need to do that, but it does mean committing to them, to letting them be, and not fighting or resisting them. Which we know can only make them more intense. There's lots of psychological research about how if you resist difficult thoughts and feelings, they actually come back much stronger. It's about actually approaching difficult thoughts and feelings and actually focusing on them, which can feel, and exploring them, which can feel very difficult, and it's not an easy thing to do, but can be really helpful for people. The fourth thing is something called self as context. And I guess this is one of the most complex parts, I think, or the observing self, that it means realizing there is a part of us that is aware of our thoughts, feelings, body sensations. We, again, aren't these kind of thoughts, feelings, body sensations. There's a part of us that's aware, and that is, however difficult or painful these might be, we aren't just these things. And we have this awareness that can watch these things as we think and feel them. It's an us that will always be there throughout all our experiences, and sort of allowing oneself to hold on to that is really, I think, very important in ACT. And again, a difficult thing to do. Fifth principle is something called values. And I guess this does what it says on the tin, really. It's about recognizing what really matters to you and how you want to live your life. And I think clarifying values is really important. Lots of people, and I think I include myself in this sometimes, aren't always clear of how they best want to live their meaningful life. And I guess the values is about that, what's important to you, regardless of any challenges you might be facing.
These will be totally, they vary person to person. That's what makes everyone different, that different things matter. But an example of a value could be, maybe it's really important to you to give back to your local community, or maybe it's really important for you to feel really up to date with what's going on in the world. Or your independence. It might be very important to you that you are able to do things on your own and independently. So those are the sorts of things that are our values, those kind of guiding principles that you take with you through your life that make things meaningful to you.
And I guess that connects very much with the sixth thing, which is something called committed action. And this means taking action in line with our values. So I guess by being really explicit about what our values are, it then means we can do things that are in line with those. And the idea is that it's not enough just to know what your values are, but to actually take action in order to be in line with them is really important. And I think that's a key kind of thing within ACT. It has the idea that it's not just about knowing, it's about acting in line with that. And I think Emma, you're going to talk a bit about how sometimes that can then mean adapting what you've previously done, but knowing the value gives you a bit of a beacon for how to adapt that, so you're still living in line with your value, but doing it slightly differently because of the PCA.
Yeah, totally. So I think, it's about finding new ways often, I guess, because of those difficulties, to still make sure you're acting in line with those values. So, for example, someone who does really value contributing to their local community, they may have previously volunteered in their local shop, working the till, and perhaps that is now becoming really difficult because of the PCA symptoms. So it would be about finding a new way to connect to the local community and feel like you're contributing to it. So it might be in maybe a more befriending type of a role, when you can rely more on being able to have a conversation with people, and just finding new ways, I guess, to still connect to the things that matter to you. Another example, so if we think about that person who perhaps really values their independence, doing things on their own, and wanting to be connected and up to date with what's going on in the world, maybe that person used to read the newspaper every morning, and that would become very difficult potentially with PCA symptoms. For that person, their committed action might be using kind of text-to-speech apps with things like the BBC news pages to have the information read out to them in an audio form. So it could still be something they could do themselves. They wouldn't necessarily have to rely on others to help with that. And again, it's a way to still connect to that thing which is really important. So staying up to date, knowing what's going on.
Thanks, Emma. And so I guess ACT or acceptance and commitment therapy has these sort of values elements and action elements, but also these other things about how you manage, live with, understand the difficult thoughts and feelings that you have, and ways of sort of accepting them, understanding they're not part of that they are part of you, but they're not you. You have a separate self, and using these exercises. And hopefully we've given you a bit of a flavour of that. I mean, ACT is just one way of working, one sort of psychological therapy of working with people. And I guess, as Emma will say, I guess what we're really keen to do is to try and develop the evidence and the sort of adapt therapies so that they're optimally suited to people living with PCA and their supporters, so that we can support them and others can support them.
Yeah, so that's definitely what we hope to do, because we know there are these psychological approaches out there, and often they will have been shaped for people with dementia, but we know that for people with PCA, there will be specific challenges and difficulties that don't quite fit with that general assumption of what it means to have dementia. So it's really looking at trying to start developing and tailoring some of these existing interventions for people with PCA and their particular difficulties. And we hope that will be informed by some parallel work that we're doing in the clinic here at Queen Square, but also by associated PhD projects that are going on within the Dementia Research Centre. And we'd really hope to be in conversation with you about that as we develop our ideas, and so hope to run some focus groups later in the year with you, any of you who may have engaged in psychological therapy, to know about how that went, any barriers, any challenges, your expectations and hopes for it, and also anyone who has steered clear of it or hasn't been able to engage with it for any reason. We really want to know what helps, what doesn't, and what the needs are. So we look forward to being in touch with you about that as the year goes on, and hope to also come back and talk about other types of approaches, just to introduce them and give you a sense of the possibilities of what is out there. And thank you for your time today.
Wonderful. Thank you so much to Emma and Josh for that very approachable and practical explanation of that particular type of therapy. And I hope it's encouraging for those of you who perhaps haven't had a previous experience of a psychological therapy, or aren't sure what that might look like or feel like. I think it's really helpful hearing the different elements of that particular ACT therapy. I was particularly thinking when Josh was talking about acceptance, that element of it, and the sort of acknowledging difficult situations and making room for them. I kind of feel that that's what everyone here has done in coming to a meeting like this. For some people that would have been very easy and you wouldn't have had any hesitation, but I suspect there'll be some people in our group who maybe this time, or maybe the first time they came, remember that sort of slight push-pull feeling of not being sure whether you can really do this, not being sure whether you want to hear what you might hear at a meeting like this. So just want to acknowledge all of you for approaching a group like this, knowing that it will hopefully be helpful, but also wary of what it might contain. And as we always say with all of our meetings, we're very keen for everybody in their different places, being different people, and if in the different stages of their condition, to take with you away from this meeting what is helpful for you, and to feel free to leave what's not, or maybe for another time. Next up for our meeting today, we have a video in which Olivia Wood, one of our direct support team members is going to be interviewing Roger and Martine, two of our members, particularly about their experiences, well, about their story, but also about their experiences of small groups and meeting with others with similar experiences. So I shall hand over to Livy to introduce that.
Hi everyone, it's Livy from the direct support team, and I'm extremely excited to be joined today by the lovely Martine and Roger. And just to get us started, could you both give us a brief introduction for the viewers watching today?
Good day to you, Livy. Well, I'll start off. I'm Roger. I'm Martine's husband, originally from New Zealand. But lived most of my life overseas, and we met in Sheffield when I was at university in Sheffield, didn't we?
Yes.
No.
Yes.
And you were working there, and the rest is history, as they say.
Indeed.
And up to date, we've been married for 44 years. Need a new husband after a while now. Probably.
No.
You sure?
No, love you.
And really, apart from that, we sort of lived and traveled around quite a bit. Lived in France, we lived in London, then Hong Kong. We went there for 3 years and stayed for 14 years.
Amazing. And can you tell us a little bit about Martine's PCA diagnosis?
Well, properly diagnosed formally how many years ago now, Martine? Remember? No, 4 years ago, wasn't it? 4 years ago. But, you know, back in 2015, you'd sort of noticed that there were a few problems, and we went to see the GP while we were still in London. And I remember you saying, you know, your memory was not so great, and somehow the conversation then got on to the GP asking you if you had anything else, and you said you had a bit of lower back pain. And for the next 3 or 4 months, they sort of focused entirely on whether your kidneys were okay. And by that stage, we were sort of leaving, and we moved to France. And I can remember you phoning me because I'd come back to London to help with our daughter Natalie's flat, and saying that you'd gone round to see Dr. Baudin because you wanted to see what was wrong with your memory.
Indeed.
Yeah, that's right. Yeah. And then there was a nurse that came to the house and did a few tests, memory tests. And then you had not 1, but 3 scans.
Yes. Yes. Maybe more.
No, well, it could have been more. Yeah, you're right. And then we went to see that neurologist in the town, and produced a piece of paper and said, well, it's Benson syndrome. And we didn't know what that was.
No.
he almost seemed a bit embarrassed by it, really, because we sort of talked about it, and we said, well, you know, can you drive? Oh, no, don't drive. And that was that. And then he said, it was really an odd conversation, because he said, well, the best thing to do is to come once a week to the day hospital in the town, and we'll try and stabilize it. We don't know where it's going to go, but if we can stabilize it, that would be good. And so at a time like that, you're really sort of clutching at any opportunity, any chance. So we thought, okay, fine, stabilize, etc. So you went to that once a week, and it was fine with the other ladies, but you know, it was basically a game of Uno in the morning, or make a cake, and then a walk around the town. So it wasn't terribly intensive. Then it was sort of, there wasn't really any sort of cover, because we were in a village in quite a remote part of France. I don't remember how it came about, but you ended up with Magali, the speech therapist that you saw once or twice a week for half an hour. And then you had an occupational therapist that you're only allowed a quota of 6 visits a year. So when she'd done her 6 visits, that was it. End of that. You remember Bridget that came to, you made quiches with her and things like that.
Yes.
And then I guess, you know, our GP announced that he was retiring, Dr. Vaudin.
Yes.
And we tried to find another GP, and within, you know, a 50-kilometer radius, they all refused to take us, saying that they were full. And I think, you know, that sort of, because it was remote, and it felt very isolated, you know, it sort of, I think it's a fairly common experience with anybody with a dementia or rare dementia, is that it's almost as you've got a red cross on the door for the Black Death. And we were sort of sitting there through the summer in 2019 without really seeing anybody. I think the only people we saw were our very good friends of 30 years, Audrey and Bernard, that always stayed with us.
Yes.
And we just sort of decided to be closer to our daughter, who lives in London, and friends that we'd known over many, many years. It made sense to move back to London. Our good friends here had a look at this house and said, be perfect for you. It's in a gated community. And so we came. Little did we know that we would be moving from France the day after lockdown started in France, and moving into the house here the day after lockdown started in England. And got a community nurse that comes. We've got Oshika that comes to see you twice a week, and you go out and do games and that. And now as well, with things getting easier, you've got the day center every week, which is good because it allows you to do what you like doing, which is mixing with people and meeting with people, rather than me and the dog, or the dog and me.
Oh, and I know that you both do a lot of activities together. Can I ask about the activities that you enjoy doing, and maybe how you've adapted activities over time?
You like cooking and that, but now we do it together rather than you doing it by yourself. So when we can,
I don't mind doing it with someone else, you know.
What about me?
No, I know, but you know, if you were not there.
Okay. What else do we do? We obviously we've got the dog, who's very energetic, so it's good to go for walks and explore different places. And we're very lucky in southwest London that we've got plenty of green areas to go around it. And it's nice as well to go down to Wisley, to the garden centre. Yesterday you went to the wetland centre with Oshika. That was good, wasn't it?
Yes, it was.
Did you see any otters there yesterday? No, they're all hiding away. Okay.
It does happen.
It does, yeah. You know, the only other thing is that you sort of, a lot of it is COVID related, but you do miss the company of friends and sort of being able to sit down and have a good chat. And
of course.
You know, that's always more difficult, but you know, it will come. And as I say, with the day centre, you've found new people to talk to.
Yes.
It's good fun to do that again, isn't it? Yeah.
Well, that's brilliant. And I know both of you have been involved in some of the small groups run by Rare Dementia Support. So groups like the Couples Group, which was last year. Can you tell me a little bit about your experiences of the small groups you've been involved in?
We're still in touch with at least one couple from that on a regular basis. Sort of every 2 or 3 weeks, we have a Zoom call, which starts off for about half an hour. Always find something to talk to. So finding those bonds has been good, hasn't it?
Yes.
Yeah. And then, you know, in the creativity club, you really enjoy that, don't you?
Yes.
Yeah, to do the artwork and that.
Yes.
It's good, isn't it?
Oh yeah.
And the small groups that for the carer side, I find, you know, really invaluable, because, you know, there are times when you sort of really feel as though you're walking through treacle, and to realize that other people are also walking through treacle is quite reassuring. So it's a good feeling. to continue the analogy, you sort of get a bit of a spring in your step afterwards. And you sort of realize that rather than trying to do everything by yourself, that there is a network out there, whether it's the support group or whether it's other people that you can talk to, and you grow stronger from it.
You can only ask.
You can only ask. You're absolutely right.
That really nicely brings me on to my next question, which is, how valuable have you found being involved in groups with other people living with dementia or other people caring for somebody with a diagnosis of dementia?
For the being part of those groups has been fantastic as well, because it's sort of, every session is always a bit of a roller coaster. You're sort of going all over the highs and lows, but at the end of it, you do come out with, a feeling of positivity about where you are, and that it's
possible.
Yeah, things are possible to achieve if you just sort of, if you're honest in your approach about it, and yes, everything else.
And I know Creativity Club, which you touched on, is something which you both really enjoyed, and I was wondering if you could tell me a little bit about your experiences of Creativity Club and maybe how you feel when you're in Creativity Club.
Not odd, because if I don't know anything, I find it quite difficult. But as you go along and so on, it's fine.
And then people are sort of helping you and
yes,
sort of showing you. And
yes. Yeah. Not all of them, we're all different, so, enough to...
A bit of coaching.
Yes.
Yes, yeah. Yeah, I think it's from my perspective, it's just really the admiration of it shows, that sort of this is not an illness where you're sort of written off and cast aside, because the ability to be creative, the ability to produce such art that everybody in the group is producing, whether it's painting or sculptures or ideas, concepts, and poems as well, or just writing. It just shows that
it's still possible.
Everything is possible.
Yeah.
And I think that's the unfortunate thing when people sort of dismiss people with a rare dementia. They just don't understand how much ability is there.
Well, we can tell them.
But that is creativity for me is really the gold standard for what you would look for in empowering your identity. That is for me the true meaning of empowering your identity by expressing yourself through art and everything else.
Yeah.
Fantastic. So to finish up today, what I'm going to do is I'm going to be bringing up a wonderful poem which was actually written by Martine during Creativity Club on the theme of friendship, which is amazing. And Roger and Martine are going to be on our Q&A panel today. So if you have any questions for them, please do send them along using the question box. And thank you so much today for watching.
Wonderful. Thank you so much to Livy, Roger and Martine for sharing their experiences there. And I certainly, for one, feel really encouraged to hear Martine and Roger talking about their experiences of the small groups as showing them what's possible, and absolutely agree with that point that people often don't understand how much ability is there. And sometimes when we talk about the strengths and abilities that persist in spite of conditions like PCA, people can assume we're trying to have this very positivist, ignoring the difficult stuff and only focusing on living well and those things which are difficult for any of us at any stage of life. And I think what comes across in their conversation is a much more honest and authentic balance of acknowledging what's difficult, but also in amidst that finding how to make the very most of continued strengths and passions and interests. Really inspiring. Thank you. Before I hand over to Emma to chair the question and answer panel, we've got one more short video for you today, which is Karen Tapson talking about the new peer-to-peer or peer support groups for people with a diagnosis of PCA. So I'll hand over to Karen.
Hello, everyone. It's lovely to be here. Before I get started, I'd just like to say a very special hello to all the members of the PCA peer support group that are watching today. Roberta and I have had the privilege of facilitating these two fabulous monthly peer support groups now for 5 months. And I must say it's been a complete joy to watch the groups get to know each other, really bond and support each other. They really are so inspiring. The PCA peer support group is just for the person with the diagnosis, but we do understand that family may need to help set up the tech. And it's a safe place to share their story, listen to others, support each other, and I must say, just have some fun. We facilitate 2 groups, both on the 3rd Monday of every month, and one at 11 AM and the other at 1:30. And that's via Zoom. Members of RDS come from all over the world to join us, which makes this group even more special. So I've had an opportunity to ask members what they think of the group, and I just wanted to spend a few minutes sharing with you what they said. You're not as alone as you think you are. This really resonates with me. When I meet a person with a rare dementia, often the first thing they say to me is, I thought it was just me, as they'd never met another person with that condition. And this often meant that they could feel quite alone and isolated. For me, it's when people living with PCA come together and help each other. Lots of members fed something back like this, and it's that wonderful feeling about being together. One member described it as an open mic. Everyone who wants to talk gets their say. Another said, it's a safe space. I know I'm with my peers that have the same diagnosis. I am in a lot of support groups, and most of them, I'm the only one with PCA. This group is just for RDS members living with a diagnosis of PCA. It's such a privilege for us to be able to offer this support group. The ability to compare experiences and find out more about PCA. The opportunity to hear what it's like for other people with PCA. We need to remember it's that individual journey. People experience different symptoms when they have PCA. Things understood, they don't have to be explained. It's not a whitewash, all the positives, ignoring the negatives. We know that there are tough times, things can be difficult, tough days. A member of the group said, we keep it real. An opportunity to unload in an environment that others understand what we're dealing with. Everyone supports each other. They're all experts living with PCA 24/7. And this last one's a lovely quote. The group's a godsend. I always come away feeling good. So here are 3 quotes from a member that I wanted to share with you, as it really underpins what we hope to achieve in creating these very special peer support groups. It's a bit of an anchor, people that will listen and understand, you know, that connection, something to hang on to, that feeling of being together. A resource, everyone being their own expert living with PCA, and we had some very positive feedback about the importance of the expertise of the group leaders, the direct support team, and RDS as an organisation. So we asked everyone to use 3 single words to describe the PCA group, and here is what they said. Some really powerful words are here, and they all really speak for themselves. So very special. And one member shared this lovely quote with me. And what they said is, when a PCA peer support group goes well, it makes me feel a bit more positive. Then I feel a bit more capable, and then I will be a bit more adaptable. How amazing is that? So I asked the members of the group if they would tell somebody newly diagnosed with PCA about our group, and overwhelmingly the answer was yes. And in fact, people were already spreading the word. And one very wise member of our group says, give it a go. And if it maybe isn't what you think after the first meeting, give it a second chance. It can take time, to get comfortable, make those connections, especially if you haven't used an online platform before. Every meeting is different. Some are very positive, while other months we may discuss some difficult situations. The most important thing to remember is this is about support. So if the meeting covers some difficult issues, we are here and we can offer that one-to-one support as well from the direct support team at an appropriate time. So before I close, I just want to invite everyone that's listening that has a diagnosis of PCA and would like to meet others living with PCA to contact us at the contact email address on this slide. You just need to be a member of RDS, and we look forward to welcoming you to our group soon. Lastly, before I finish, I just want to say a huge thank you to the members of the PCA support group for your fantastic feedback. And Roberta and I will be looking forward to seeing everybody for our September meeting, which will be on Monday, the 19th of September.
Hello, everyone. And yeah, really good to be here. If I could welcome our panelists onto the screen. We'll start the Q&A session shortly, and that was a lovely lead into it with that video from Karen, hopefully building on Roger and Martine's interview and giving you an idea of what you can expect from the kind of peer support groups that we're running. So very happy to welcome our panelists back and very happy to be here today to chair questions. So I'm Emma Harding. Hopefully I know most of you watching, but if not, to meet you virtually. So we have all our speakers back, and also we have Dr. Keir Yong joining us. Keir is a senior research fellow at the Dementia Research Centre with lots of experience with PCA. So great to have you here as well, Keir. I'm going to kick off with the first question, a bit about some of the confusion we can often hear about in terms of diagnosis and understanding what's really causing or underneath PCA, because it can get very confusing, I think, as we've heard for people with the diagnosis, but also for professionals. So someone has asked what causes PCA, and another member has said, my husband has now been told he's also got Lewy body dementia alongside PCA and Alzheimer's. Is this common, and what are the potential pitfalls? So I wonder, Keir, if we could come to you for a bit more of an understanding about causes of PCA.
Well, thank you, Emma, and thanks for having me. Just to apologize in advance for my very creaky internet connection, so please feel free to ask me to repeat any bit of what I'm saying. So this clearly isn't a trivial question, what causes posterior cortical atrophy? So some people would really consider posterior cortical atrophy to be a syndrome, as Robert very scholarly outlined. This could be considered really a constellation of different symptoms, but because PCA is considered a clinical radiological syndrome, we've had the clinical bit in terms of symptoms. The radiological aspects really refer to what we call supportive imaging features. So we heard Robert talk about things like a SPECT scan, a PET scan, also a FDG PET scan, which can look at things like really the integrity of parts of the brain, particularly towards the back of the brain, both in terms of their structure and also their activity. So because PCA is a syndrome, it can actually have different underlying causes. So by far the most common cause of posterior cortical atrophy is Alzheimer's disease pathology. So these tau tangles and amyloid plaques. But in some cases, PCA can arise from other neurodegenerative diseases. So for example, Lewy body pathology, alpha-synuclein proteins, and also in some very rare cases, things like cortical basal degeneration or prion disease. So to go to this particular question about coexisting Lewy body pathology and Alzheimer's disease pathology. So my understanding is that actually for people with Alzheimer's disease, a higher proportion than you might expect can also have Lewy body pathology. So these are alpha-synuclein proteins. So this can, in some cases, manifest with certain symptoms. So, for example, complex visual hallucinations at a relatively early stage of someone's disease course. Other symptoms like things like Parkinson's or some sleep disturbances. But I think of these, and emphasizing that my area is posterior cortical atrophy, it's not specifically dementia with Lewy bodies. Confusingly, some of these other symptoms, particularly outside complex visual hallucinations, can also just arise from Alzheimer's disease. But where this can have implications is in thinking, well, number one, of certain treatments, where of things like Parkinson's related movement symptoms, some people might respond to L-DOPA treatment. But also, and emphasizing I'm not a clinician here, my understanding is that people might want to be careful if they do have coexisting Lewy body pathology and Alzheimer's disease pathology about certain dopamine antagonist treatment, that people might respond not so well to those. So it can be something that's definitely worth discussing with someone's clinician if there's a suspicion of, again, not only Alzheimer's disease, but also dementia with Lewy bodies and Lewy body pathology. But just to emphasize, just because some people have some of these movement symptoms, it doesn't mean that they necessarily have coexisting Lewy body pathology. For a lot of people, that is just caused by Alzheimer's disease for reasons that we don't fully know.
Thank you, Keir. And I think, yeah, that captures what a complicated picture it is. And if people do have questions, yeah, do definitely follow up with your consultants. And it's really important that things are explained to you in a way that you obviously can understand and make sense of, and know how to deal with. Related to that, we had another question from someone who said that their mother-in-law also has macular degeneration, and the vision problems they have seem to overlap very much with what you were describing, Robert, in your very helpful overview of PCA. The particular question is about the doctor not maybe being aware of PCA. So I wanted to come to you, Robert, because I think lots of people experience that, and it's very frustrating often, but you have really managed to channel that, what must have been quite frustrating, into some great education of professionals that you've done. And I wondered if you could just share with everyone sort of how you've gone about that and the different professional audiences you've spoken to about PCA.
Sure. I had major difficulty without wanting to rubbish the general practice, but doctors are so busy, they allow 10 minutes for a consultation, and it becomes incredibly difficult. Initially, Catherine used to go to the doctor on her own, and she'd come back, and I was at work. I worked away quite a lot. And I'd say to her, so what did he or she say? And she said, I can't remember, but I was fine. Which is always a problem, because the doctor would say, so how are you feeling, Catherine? She'd say, well, I'm fine. So what are you doing here? I'm not sure. And that was really difficult. So I then adopted the practice of insisting that when she went to the doctor was aware that I was going to accompany her into the consultation room, and I would go in with a notebook and write down everything I could possibly record that the doctor said. And she said to me one day, so you're writing all this down, are you? I said, yes, because we just need to know exactly what's going on. So I followed that through, and then I was fortunate to get referred to a cognitive assessment unit, which then existed very close to us in West Sussex, with one trust that was assigned this small team attached to Brighton University. And from there, it really became an eye-opener for me, because I met so many specialists then through that very small team, which unfortunately was disbanded, and it was then amalgamated into another trust. But I also got referred through, a healthcare professional came to assess me as a carer to see how I was coping. And she very kindly, having told me how to manage Catherine in terms of helping get in and out of chairs, how to lift properly without straining my back and ruining my health, she referred me to this proactive care group. And once I got into that group, I found there was an amazing wealth of experience and expertise, which I could then plug into. I also got referred on to another charity who through them, I found access to other professionals, and then I came across RDS, the Rare Dementia Support Group. And I was in fairly soon in, I think, back 2016, when it was almost beginning, and meeting people there, meeting Seb, and Catherine was then discharged from the clinic in London to our local GP, and the correspondence that went between the doctor and the consultant started to sort of peel back the mystery of what PCA was. And I also talked to our optician that Catherine saw quite regularly, every 2 years with her eyesight. And I had to explain to the optician what PCA was, because they were about to prescribe another £600 of glasses, since they thought she needed another prescription, which clearly she didn't. It was, she couldn't see the television because she just couldn't process what she was seeing. I don't know whether that's helpful.
Extremely helpful. Thank you very much. Keir, I see you unmuted. Did you want to add something to that?
Well, if it's okay, I was just going to very quickly chip in with, I think, something that speaks to both the question regarding similarities to Asperger's in terms of certain symptoms, as well as with macular degeneration and PCA. Because in one sense, you could argue that there's some parallels, at least for macular degeneration. If you have loss of central vision, some of the things that Robert described in terms of difficulties with, say, hand-eye coordination, maybe missing things that are right in front of you. And in the context of, again, what I'm aware of secondhand regarding autism, with some people having certain visual symptoms, so less efficient visual search, sometimes maybe being overloaded by certain types of sensory information, might have some parallels, say, with people with PCA who experience particular difficulties recognizing objects amongst clutter. But that just because superficially these might share certain characteristics, it doesn't mean that they share the same basis. So I'll just pick out one example. With macular degeneration, because people can lose their central vision, they might be more reliant on using their peripheral vision. And this has got a couple of downsides. Number one is that our acuity tends to be worse in our peripheral vision than central vision. And number two, that all of us, regardless of whether we have PCA or not, experience something called excessive crowding in our peripheral vision. So crowding is one reason why it's very hard for us to pick out a face in a crowd of people out of the corner of our eye. And it's one reason why people who've got central visual loss from macular degeneration really struggle with reading. Because imagine if you're reading a page of text and using a peripheral vision, all the words tend to jumble up. But for people with PCA, they can experience difficulties that are in line with crowding, but in their central vision, so when they're looking directly towards something. So I'm just using this as an example about how, while there could be some parallels, that doesn't mean to say that there's necessarily a shared basis.
Thank you, Keir, really helpful. If I could come to you now, Roger and Martine, there's a question about practical strategies and adaptations that you might have found helpful, particularly with eating is in the question, but anything that you've found particularly helpful that you'd be happy to recommend to others would be great to hear about.
I think many of the things that Robert talked about are sort of common themes, because we've put in sensory lighting in the bedroom to find a pathway. Eating wise, I think, Martine, we find it easier if you use a white plate rather than a colored plate, so that it's easier for you to see the food on it. What do you think?
Yes.
Yeah. And to sort of, yeah, you find it difficult at times with food on the plate, don't you, as to be able to see it and what's there or not, because sometimes you'll be just sort of scraping the rest of the food off the plate, or just to make sure that it's gone. Does that help at all? I think the other thing we try, generally to try to keep the day to pretty much the same routine. So it helps, doesn't it? Yeah. So it's breakfast. We've got some meditation tapes, so Martine will listen to a meditation tape for about 20-30 minutes, and then we'll take the dog for a walk for about 45 minutes, an hour. Lunch, you tend more to have a nap in the afternoon now, yeah? And then a bit of TV late afternoon, a drink, which is sort of apple juice or whatever. And then I'll take the dog out again while you're watching the TV program you like. And then we'll have dinner, and you know, that's basically just trying to keep it stable. But I mean, you know, it's one of those things where even if you try and plan it, it's difficult to plan. So it really has to be, you know, take each day as it comes, and not try and put in place too many sort of steps. I tend to find that it's easier to deal with when you sort of broach a certain issue or difficulty than trying to prepare for it, if that makes any sense.
Yes.
That's really helpful. Thank you. Yeah, some of those very concrete things to do, but also just your general outlook and approach is really helpful to hear about. Thank you. Livy, did you want to add anything to that?
Yes, so I'm just really enthusiastic on talking about strategies. So just thought I would chip in there. So we know that meal times can often be tricky for a lot of people living with PCA, and there are some strategies. So things like using a spoon rather than a fork can sometimes be helpful. Using a steak knife to cut all food, maybe using a dish with a curved edge rather than a plate so that the spoon doesn't spill off the sides, or using a bowl again which curves inwards for eating things like soups. And then again, maybe picking or choosing softer foods such as rice can sometimes be helpful. But direct support team really happy to discuss strategies on eating or any other symptom as well. So if you ever want to discuss strategies more, then please do drop us an email.
Yeah, I just wanted to add one thing as well, which is on my to-do list for the next time I go to the shops, is to buy some coloured glasses, because drinking out of a plain glass is very difficult. And, you know, I think it's easier if the glass is blue or green so that you can see it, because if you've got water in a glass and the glass is clear, it can be quite difficult for you, can't it?
Yes.
Yeah.
Something that comes to mind is one research participant who I work with who actually used a Guinness glass to pick out her glass relative to other objects as well, because that's something that chimes with the experience of a lot of people, is difficulties with completely transparent glassware without any kind of visual cues. And also on that point on cues, Livy, that deep dishes, people getting those kind of tactile feedbacks as well. So it's both visual and this kind of feeling for food, where you get that extra boost from knowing when your spoons come into contact with the relevant part of the plate or food.
I thought Keir there was going to advocate sticking with a clear glass and just drinking Guinness, because that's also quite visible, but that's another strategy, plain glass and a coloured drink.
I did have one research participant actually who said she'd moved to rosé wine instead of white wine because it was easier to see. Robert, did I see your hand go up there? Do you want to add?
You did, but Livy's covered a couple of the things I was going to say, which was, I mean, one of the things I found was soup in a cup is a much better way of doing it than trying to slurp it out of a dish. The wide-rimmed dish, I replaced all our crockery with that. I would suggest, Roger, if you're going to replace glasses, that you actually get something that's Bakelite that won't smash. And yellow is a very good colour, apparently, to pick up. And red. I mean, one of the things I did was replace the toilet seat in the bathroom with a red one. Quite difficult to get hold of and quite difficult to fit nowadays because of the designer toilets, which we don't have. But yeah, it made a huge difference because there was something to aim for, as it were. Excuse the pun.
Great, thank you, Robert. We've also had a question about accessing support outside of London, and obviously that's a great thing that these webinars allow us to do, is reach people from all over, so it's great if you're joining us from further afield. I wondered, Livy, if you would be able to say a little bit about what the direct support team can offer in terms of connecting people up with local services?
Yes, of course. So the direct support team supports not only people in the UK, but also worldwide. So we have lots and lots of members from abroad as well. And we're able to either signpost or discuss things with you further. We do have regional groups, so smaller online support groups, and you can get in contact with us or look on the RDS website if you look under community meetings, regional groups, and you'll be able to see a calendar where they are. The format of these meetings can range from a small discussion group where members are encouraged to talk about whatever they would find most helpful, to larger meetings like these ones, which are speaker-led, and we talk on a range of topics. But we are striving to make these meetings more accessible. So you will see that there are more and more groups popping up all over the UK. And at the moment as well, we, as Karen amazingly updated on, we have our wonderful peer-to-peer support groups for people living with dementia. So although that's not a regional group, it means that anybody can join. So whether they're in the UK or elsewhere, they can join. But please, if you do want to discuss either regional support or any other support which might be available to you locally, then please do drop us an email and we'll be able to chat about that a bit further.
Thanks, Livy, that's great. Seb, is that your hand up?
It is. I was just going to add that, as absolutely as Olivia points out about the individual and group support, but also just to say at an organisational level, Rare Dementia Support is also trying to work with other partner organisations to make sure that the support people with PCA need is available in more places, not just with RDS. So, for example, we're working with the Alzheimer's Society, who are changing quite a lot at the moment, and thinking about what would a sort of a tick list or shared care protocol, if you like, look like for people living with PCA, and talking about some training that we can do, how the organisations can learn from one another, and particularly how we can work with dementia support workers across the UK, and who may not see people with PCA very often, but so that they know both have some support, some kind of highlights to make sure they cover with people with PCA they meet in their own area, and also so that they know how to come back to people like Livy for some more in-depth support when they need to. So it's both at an individual and at an organisational level.
Great, thank you, Seb. And a question here, going back to professionals again. So if people are reaching out to local professionals in their area, how can they best describe the visual symptoms in PCA to different professionals so that they can understand? I don't know, Seb or Keir, if you might have a take on that.
Sure, I think Keir, I'm sure, and others will probably comment too, but my view is often that what gets through to a given professional, to any of us who kind of identify with a particular group or professional training, is to have someone else from our tribe say it to us in as simple and briefer terms as we can. So one of the things Chris Hardy, our education lead, has been doing is establishing a set of expert to expert videos where he's capturing a conversation between someone living with or supporting someone living with PCA or another rare dementia and a particular professional they've come into contact with, and they're both kind of interviewing each other, so sort of equalizing the expertise, acknowledging the expertise in both camps, and seeing what words people use to describe, to convey their experiences, both from a professional talking to someone living with, but also for someone living with talking back to that professional. And the sort of next step for us with that is to try and find ingenious ways of sharing those sorts of videos and tailor bits of information with particular organizational groups. Sometimes that happens informally. So, for example, a colleague, Gordon Plant, who's an ophthalmologist, has written some really clear and concise advice for other ophthalmologists, saying if you're seeing someone who you kind of get that feeling it's a brain sight, not an eyesight thing, for people with PCA, these are the 2 or 3 things you should really be looking out for. Not just you should know, be an expert in PCA, which is tricky for people if they're not meeting many people, but saying be inquisitive if you see someone perhaps performing or responding to one of your common tasks that you use all the time in a slightly unfamiliar or unusual way. So, for example, if you're doing a field test with someone where you have your face stuck in a scanner, in a sort of a dark screen, and you're asked to click a button every time a flash of light appears, be aware that people with PCA respond in a very distinctive way to that, with quite a lot of inconsistency about sometimes seeing it, but sometimes not. But Keir can perhaps talk about some of the work he's done with other groups like occupational therapists and others.
Thanks, Seb. And just to agree with everything you've said, and also to say that, as we've heard, unfortunately, a lot of the symptoms people are experiencing are very counterintuitive. So already that in itself is one barrier. But I thought Karen had a lovely description of some of the feedback from the support groups. And one of the benefits is people don't have to spend 5 to 15 minutes or longer with a preamble to really describe some of these symptoms to people who really get it. So in terms of stuff that we've done previously with different professional groups, so we put out continuing professional development courses for the College of Optometrists, also work with Moorfields Eye Hospital. We still got links with Moorfields Eye Hospital. And also we put out some training for the Royal College of Occupational Therapists. That was 2 years ago, which we're just updating now. And we're updating it to include not just visual symptoms, but some of these disturbances in sense of space. For example, Robert mentioned difficulty locating the sleeve of a jacket behind oneself while getting dressed, or also things like someone's internal compass being slightly skewed sometimes, so that sense of direction being somewhat less reliable, but that not necessarily explicitly relating to vision alone. So our updated training will now include, again, some of reference to some of these symptoms. But the other things I thought to mention is, for example, we're doing some work with different care home professionals and people who work in community settings. But I think what really has to be center stage here is, as Seb mentioned, people describing their own lived experience, and whether that's with things like the do you see what I see animation, which can be very evocative in terms of people's symptoms set to animations of what those symptoms might be like on a subjective level, because I think it really cuts through to people much more so than very dense medical terminology. And on that last note, we put out a review recently in the Lancet Neurology, which we hope will be relevant to a very wide audience. But actually, we use the term visual spatial rather than posterior cortical atrophy throughout, because we hope that this will be more intuitive to, say, some professionals outside neurology. So people like occupational therapists, physiotherapists, speech and language therapists.
If I could just say one other thing, this is another great opportunity for members of the wider PCA support group to be involved. I mentioned videos earlier, and finding those professionals who, from different backgrounds, who've gotten experience or have some understanding of PCA, who could potentially talk to their colleagues who've never yet met someone with PCA. If you know someone, if you are, I think probably most of you will have one or two key people outside of your main neurology team, or whoever provides you with most support, who you've met, who kind of just get it. They wouldn't call themselves PCA experts, but they've been really receptive to you. Perhaps they've read the stuff that you've shared with them about PCA, or they've shown it a level of inquisitiveness. If you can think of anybody who you could ask, hey, would you be up for doing a little video for RDS, either just them, the professional themselves, or you in conversation with them, we'd love to hear from you. One of our colleagues, another fantastic member of the group, Val Mansfield, whose husband lived with PCA, she listed out the number of different professional groups she had come into contact with during their time. I think the number approached something scary like 40 or 50 different types of professional, not just in the community, but also separately in hospital when Peter was in. So there's quite a lot of scope for us to reach a lot of different audiences. It's not just about the GPs and the neurologists. There are loads of other people in the community and in different settings who we could try and reach out to. So if you can think of someone who you think would be interested in just making a short 2-3 minute video, very low stress, we can do it where you are, where they are, via Zoom. Please do feel free to let us know.
Thank you, Seb. And I'm conscious of the time, so that's all the questions we've got time for today, but we haven't got through them all. So I just want to echo Livy's encouragement that whenever you have any questions, don't see it that you have to sort of hang on for a webinar. you can always contact the direct support team. And even if you just want to check in, if it's a very concrete question, they'll always be happy to hear from you. And someone will be able to get in touch. So do send your questions in to contact@raredementiasupport.org whenever you have them. And I'd just like to say another huge thank you to all of our panelists for bringing your collective expertise to these questions and for sharing your experiences like you have today. And to all of you who have joined. Thank you very much. We're going to close now with a short video from the National Brain Appeal about fundraising. And yeah, thank you. We'll see you soon.
Bye, everyone. Take care.
Hello, my name is Eva Tate and I'm the Major Appeals Manager and Manager of the Rare Dementia Support Fund held by the charity the National Brain Appeal. The National Brain Appeal raises money as the dedicated charity for the National Hospital for Neurology and Neurosurgery and UCL Queen's Square Institute of Neurology. The National Brain Appeal raises funds for Rare Dementia Support's 2,000 members to help individuals living with rare and early onset forms of dementia, their families, friends, and healthcare professionals. And we also hold several other funds for FTD and dementia research. The funding helps not only the support group meetings in London, but also the regional support groups, admin and support staff, and all other associated expenses, including the new online support groups. When things return to normal, there are travel and accommodation bursaries available to help members attend the meetings. This year, we've raised our fundraising target to 300,000, and this will rise further to 350,000 by 2022 to develop and extend the service in the areas of education, support, and research, with the ultimate aim that everyone affected by a form of rare dementia will have access to specialist information and support, as well as contact with other people with a similar condition. We apply for grants from grant-making trusts, foundations and livery companies and have a wonderful group of supporters, some of whom are here today, who fundraise for us in an amazing variety of ways. We would love it if you would like to sign up to our RDS fundraising newsletter to hear more of these stories and receive news of how we can support this community. We have had people do head shaves for us. We have had a gentleman drive across the Mongolian steppe in a VW Polo, and we have lots of people who take part in runs and virtual runs as well. At the end of February, we held a gala dinner called Mission Possible, where we raised 110,000 for the expansion of rare dementia support. And we are delighted to announce that in line with this expansion, the charity is committed to raise up to 7 million to create the world's first centre of excellence for rare dementias. If anyone would like to discuss any fundraising ideas or the new capital appeal, please do feel free to email me or my colleague Alexis, our Senior Fundraising Manager, who will speak about the innovative new ways you can be involved in fundraising for RDS, even during this challenging time. Thank you very much.
Hello, my name is Alexis Gebby and I'm the Senior Fundraising Officer at the National Brain Appeal. I just want to start off by saying a huge thank you to all of you who already fundraise for RDS. We really appreciate all of your incredible efforts, especially at this difficult time. My role at the National Brain Appeal is to look after all the amazing people taking on various fundraising activities for us. We have had people challenging themselves to run marathons, cycle long distances, climb mountains, and even take on skydives, all whilst raising money for RDS. We also have wonderful fundraisers out in the community who organise golf days, hold coffee mornings, host choir and carol concerts, and even shave their heads. These people ensure that more people like you can be supported through rare dementia support. If you're interested in becoming one of our fundraising heroes, then please do contact me. I am here to support you with your fundraising, and I'm more than happy to chat about any ideas that you may have. While at the moment it isn't possible to take part in a sporting challenge or hold a big fundraising gathering in your local community, we do have some fundraising ideas, such as taking on a solo virtual run or walk, hosting a quiz for your friends or family online, asking for birthday donations in lieu of going out, or even donating money that you may be saving by not travelling to work or buying your daily coffee. Do get in touch with me if you would like to get involved. In the meantime, take care and we hope to see you soon.